Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse, Transplantation, Marcus at Home welcomes Professor Giacomo Emmi in Trieste, Italy, and Professor David Saadoun in Paris, France, for an update on Behcet's disease. Dear Giacomo, dear David, it's a pleasure to host the two of you at the end of our 7 weeks academic journey that accompanied first the Tour de France and then the Olympic Games, which took us from northern Italy to Paris. Dr. Emmi originates from Florence, where the Tour de France started in late June, while Dr. Saadoun comes from the Olympic host city of Paris. So thanks for being our guests tonight. Dr. Giacomo Emmi is immunologist and professor of internal medicine at the University of Trieste at the Dipartimento di Scienze Mediche, and Dr. David Saadoun is immunologist and professor at the Department of Internal Medicine and Clinical Immunology, Hôpital Universitaire, Pitié-Salpêtrière in Paris, France, which is National Reference Center for Autoimmune Systemic Disease and National Reference Center for Autoinflammatory Diseases and Amyloidosis. Our two experts today are global leaders in Behcet's disease, with more than 100 publications written by each of them, including review articles in the two arguably most important journals in general medicine, namely the New England Journal of Medicine and Lancet, which were both published in May. So thanks again for being with us.
Thank you very much, Gunnar and Andreas, for inviting me. So I'm going to talk to you about diagnosis and pathogenesis of Behcet syndrome. A few insights about the classification of Behcet, which is usually classified as a vasculitis of vessels of variable calibers, involving both veins and arteries. Behcet syndrome usually involves young patients around 30 years old with a sex ratio of 1, but we know that young males are probably the most severe patient in this disease because they have more propensity to develop central nervous system and vascular manifestation that are life-threatening manifestation in Behcet's. Looking at the pathogenesis of Behcet disease, we can see that there are different triggers. The first one is environmental. We know that in the mouse, there's a lot of different bacteria and viruses that may trigger this inflammation. We also know that the dysbiosis is really important in the pathogenesis. And then we know that there's a genetical background in this patient. We know now from a pediatric patient that there are monogenic Behcet-like syndromes involving the NF-kappa B pathway. We know that 50% of patients share the HLA-B51, and they have many different genes that have been described in the GWAS study. Then there's an activation of innate immune system that lead to the activation of T cells, Th1, Th17, NK cells, neutrophils, and CD8 T cells that usually are targeting the tissue. And when we biopsy the tissue, we can see a lot of infiltration with neutrophils and T cells, for instance. When we look more specifically to the vascular lesion, Behcet is really interesting because it's a model of thromboinflammation and is really important based on the work from Giacomo and his team. We can see in this slide that the neutrophil and the activation of neutrophil and the different pathway of activation of neutrophil, they produce antioxidant molecules like ROS, metalloprotease, but also they produce NETs once activated. And this molecule and this neutrophil activation will lead to a pro-coagulant factors, the activation of platelets, and finally to the thrombus formation. But this thrombus is really directly the consequences of the inflammation of the endothelial cells and the endothelial dysfunction and the neutrophil activation. So that's why in Behcet's, in thrombose, in thrombosis associated to Behcet, the anti-inflammatory medication are really critical. When we look about the genetics, we can see that there's many polymorphisms according to this slide, but we can see also that one of them is really important, not only for Behcet, but also for AS or psoriasis, or also for birdshot retinopathy. We can see on this slide that AREP1 is really critical for the processing of cross-presentation to CD8 T cells. And there's a very nice study published in 2013 showing that the people sharing HLA-B51, but also sharing polymorphism for AREP1, have a high propensity to develop Behcet syndrome, meaning that the presentation of antigen is really critical in the selection of autoreactive T cell. Now we have a new vision based on the genetics and the physiopathology of Behcet of the continuum between recurrent apoptosis, stomatitis in some patients with HLA that are really close and share with Behcet also, and also with Papa syndrome, which is really close clinically also from Behcet. And we think that these different entities are really close to the Behcet syndromes. That's why some of these patients may benefit from the same medication that we can use for Behcet. There's a clear role of the genetics now in Behcet syndrome, especially in young pediatric patients when there's a family history of Behcet syndrome, when there's a history of fever, recurrent fever, inflammatory syndromes, and other signs. And in this context, we can use genetics approach to look for H820, which is a new monogenic Behcet syndromes with some characteristics that are different from Behcet syndromes. The first one is that it developed in early childhood. It's an inheritance autosomal dominant. And then, as compared to the classical Behcet syndrome, there's more GI signs, and there are also some autoimmunity and usually biologic autoimmunity that we cannot see usually in adult Behcet syndrome. Besides that, we know that there are also some very rare entities involving the NF-kappa B pathway with mutation in this pathway, like RIPK1, like REL-A, which are also autosomic dominant inheritance, with also oral ulcers that are also in the spectrum of Behcet syndrome. So that's why we have the sporadic Behcet disease or Behcet syndrome in adult patients with multifactorial genes and polymorphism. And on the other side, we have pediatric Behcet-like syndrome with sometimes monogenic mutation like TNF-AAP3 linking to the A20 protein regulating the NF-kappa B pathway. So the main problem in the diagnosis of Behcet is that there is no feature, histological feature or no biological feature. So we have classification criteria that you can see here, and we are still using this classification criteria in daily basis, but not for the diagnosis, because we know that, for instance, if we look at the vascular manifestation or neurological manifestation, 1/3 of patients will start the disease with this severe manifestation without any other signs. So that's why we don't have to wait for all these criteria to treat the patient. But these criteria are really important for the study. Then we have on this slide the different manifestations that may occur and their frequency in Behcet. You see that the skin and GI and joint manifestation are the more frequent, more prevalent. And we're going to see this in more details. The eyes inflammation occur in 50% of patients, and the more severe manifestation, CNS and vascular manifestation, occur in at least 20% of patients. The big issue in the clinical part and the diagnosis of Behcet is that you have many different differential diagnoses that you have to exclude, especially for the ulcers, because there are other causes of oral ulcers that have been shown here, like herpes, for instance. And when we look at other conditions, you can see for neurological manifestation, there's also different diagnoses that you have to exclude before starting the medication for Behcet. So when we go more to the clinics, we can see there are different phenotypes. We know, for instance, that patients who develop ulcers and are more prone to develop also joint manifestation and skin manifestation. That's probably the more frequent phenotype. We also have other vascular phenotype, vasculo-Behcet, which is really enriched in vein inflammation and arterial manifestation. And on the other side, we have patients with only ocular or CNS manifestation with usually very few other systemic signs. So the ulceration in Behcet are represented here. You have a classical minor oral ulcer. We may also experience major oral ulcer with a long-lasting lesion. We have this herpetiform oral ulcer and the genital ulcer that are quite typical in these slides. The problem in Behcet is that usually the oral ulcers are really frequent. We estimate that it's at least one flare per month. And usually the mean delay of healing reach 8 to 10 days. So it's really painful for the patient and the quality of life is really, really difficult. On this slide, you have other skin manifestation with the decreased frequency. You have the ulcers, you have the folliculitis, you have erythema nodosum, and sometimes you may also experience this patient the Verneuil disease or pyoderma. You have in this slide also other skin manifestation that we may see in this situation. This slide is to show you the pathergy, the skin pathergy that we may see sometimes. And then if we move to the other manifestation, there's a big group of manifestation, not big, but frequent for joints and sometimes for the gut, that are also shared manifestation with AS and Crohn's, as you can see in this slide. The main differences between Behcet and AS in terms of joint manifestation are shown in these slides. In Behcet, usually the involvement is oligoarticular, with involving the large joints, and also with very few axial manifestation, and the involvement of the joint is not erosive as compared to the AS. Of course, there's all extra-articular manifestation that differs between the two conditions. On the other side, there are differences also with Behcet GI manifestation and Crohn's. The first one, and the main, I would say, there's no granuloma in Behcet, never. So that's what I would say the main differences between Crohn's and Behcet. But at the end of the day, when we have to treat these patients, since the medications are really close and are really common between Crohn's and Behcet, it's not usually so difficult for the treatment. Looking at the eyes manifestation to end up with the more severe manifestation, I would say the uveitis in Behcet is really, really severe, with probably it's the main cause of blindness in industrialized countries. For the inflammatory ocular disorder, because it involves all the different segments of the eyes, and usually the uveitis is the most frequent. So the posterior complication, like macular edema and ischemic occlusive retinal vasculitis, are the main complication of this uveitis. For the vascular part, I would say it may involve, the Behcet may involve the arteries, the veins, from the head to the lower limb. It may induce more frequently aneurysm, but also stenosis. And once you have an aneurysm, it may be multiple aneurysm in 1/3 of cases. And for the thrombosis, the most severe thrombosis are those involving the vena cava and the pulmonary vessels. You can see here some different localization and macroscopic ulcer that you can see on this slide. We usually talk about vascular ulcers for Behcet, the pseudoaneurysm, as you can see here, and the very atypical localization. And these patients with vascular manifestation are more prone to develop fever and inflammatory syndromes. In this slide, you have the different prevalence of the different vascular manifestation, and the most frequent manifestation is deep vein thrombosis involving the lower limb. So to end up this presentation on the clinical part, I would just talk about the neurological manifestation involving more frequently the central nervous system of patients. It's usually considered as a cerebral vasculitis involving medium and caliber, mainly veins, because we have data on that, necrotic data. And the localization of this manifestation are more prone to develop in the mesodiencephalic junction and also to the pontobulbar and the thalamic region, as you can see here. When you have inflammation and myelitis, the main localization is usually at the cervical part of the medulla. And the MRI of this lesion look like that. You have a heterogeneous lesion with the waterfall sign, as you can see here. And sometimes you have microbleeds and bleeding inside the lesion with hyper T2, and the lesion are inflammatory, so they detect gadolinium. The main manifestation of the CNS involvement are headache, hemiparesis, and cranial nerve involvement. Sometimes you may also have this pseudotumoral manifestation, as you can see here. And in this case, in this condition, you have to eliminate, exclude lymphoma and infection. You may also have, in 1/3 of patients with neurological manifestation, thrombosis and cerebral venous thrombosis, but it's really less frequent as compared to the CNS inflammation. So to conclude this part, I would say that Behcet syndrome is really at the crossroad between autoinflammation and autoimmunity. It's really interesting because it's a clear model of thromboinflammation. It involves different size of vessel, both vein and arteries, and it's also really, really challenging for different specialists taking care of this patient. Thank you very much for your attention.
Well, thank you very much for this very powerful and important presentation. And I would just like to hand over to Giacomo, and then following his presentation, having some discussions.
Okay, thank you very much, both Gunnar and Andreas, for inviting me and to give me the opportunity to take part to this webinar together with David Saadoun. And I will briefly talk about prognosis and treatment of Behcet syndrome. David already showed this picture, obviously, which is one of the most famous picture in vasculitis, the vasculitis world, because it relates to the classification of systemic vasculitis. As David already said, Behcet syndrome is classified among the variable vessel vasculitis, but differently from all other vasculitis, which are usually involves arteries. Behcet is really keen to involve the venous vessels, and as David already said, it's like or suggested, like more venulitis rather than a vasculitis in this context. Behcet is a systemic disease. There are some manifestations which more frequently we can see in the clinical, in our clinical practice, for example, oral lactosis and genital lactosis, but generally speaking, all mucocutaneous manifestations together with articular manifestations. These are minor manifestations, but these can obviously deeply and negatively impact quality of life of our patients. And on the other side, on the right of this cartoon, you can see all the major manifestations, and among the others, for sure, neurological manifestations and cardiovascular manifestations are the one who can more negatively impact the expectancy of life of these patients. So they can obviously have an important impact in terms of mortality. So some general features about the prognosis in Behcet, which is a systemic disease characterized by a relapsing and remitting phase, and usually during the very first years after diagnosis or after onset of the disease, the disease activity is higher, usually being a male and experiencing a disease in the early onset in the childhood or when you are very young is associated generally with the worst disease outcomes. So in terms of prognosis, being a male and having an early onset disease is something negative. The increased frequency of mucocutaneous lesions has been shown to predict major organ involvement, which is something that it's quite important in our clinical practice. And for sure, ocular lesions, and David already showed us that uveitis, retinal vasculitis, are for sure important in terms of visual impairment or visual loss. But for sure, vascular involvement and neurobehcet are the leading causes of disability and mortality. In particular, I would say, and I would try to talk a little bit more in detail about few aspects of the vascular involvement. For sure, vascular involvement can modify the prognosis of these patients, and it's a very frequent manifestation in Behcet, because you can see thrombosis or aneurysms and pseudoaneurysms in up to 50% of patients. So in almost half of the patients you can see in your outpatient clinic, while neurobehcet is for sure important in terms of morbidity and mortality, but it accounts at least in Europe for 5–10% maximum of patients with Behcet. So we already saw that we can have both venous involvement and arterial involvement. For sure, deep venous thrombosis and superficial vein thrombosis are very specific feature of Behcet syndrome. Again, these manifestations are more frequent in males and during the early phases of the disease. But apart from the clinical manifestations, the recurrence of these two main involvements of the veins can facilitate the occurrence of the severe post-thrombotic syndrome, which is something that we can see very, very often in our patient. It may develop in half the cases of patients with vascular involvement, with deep vein thrombosis and superficial vein thrombosis. And this is something that obviously is not important in terms of mortality, but it's very important in terms of morbidity. On the other hand, the arterial involvement is less frequent, as David already said us, but the outcome of arterial patients with arterial lesions, especially with giant abdominal aorta aneurysms or pulmonary artery aneurysms, is really, really poor because of the risk of rupture of these lesions. One thing is, which is now recognized as one of the most important and new concept in Behcet is that we can monitor the subclinical venous vascular involvement. This is something that we already knew since almost 10 years, thanks to some MRI studies, but more recently, some colleagues, especially from Turkey, suggested and showed also by ultrasound that patients with Behcet, with or without previous vascular involvement, have a very important thickness of the vein wall, which is something that we are confident to consider in the arterial vessels, while it is something very new in when considering vein wall. And if we look at a little bit more in detail to this very specific manifestation of Behcet, these colleagues, in particular the group of Andreas and Ali Batzoner, showed that patients who have patients with Behcet usually have a significant increase of common femoral vein thickness, and in particular a increase in thickness equal or greater than 0.5 millimeter is very common in patients with Behcet, and it becomes almost unique associated with this disease when you look at the thickness of the vein wall greater than 0.75 millimeters. So if we look at the treatment of Behcet, this is the full scenario, I would say, of the drugs we can use. There are plenty of drugs, and we can consider the mucocutaneous and articular manifestations like a cluster, because it is something that's very frequent, especially in young female patients. And for milder forms of mucocutaneous and articular manifestations, usually low-dose corticosteroids or intra-articular corticosteroids plus colchicine can be enough to control this disease. But for patients with more severe manifestations or for refractory or recurrent forms, we can also use apremilast, which is actually the only one drug approved for patients with Behcet syndrome and oral ulcers. Apart from colchicine and apremilast, in very refractory cases, we can use traditional DMARDs, mainly azathioprine, and also anti-TNF alpha, especially adalimumab and infliximab. There are more recent data coming from few studies suggesting that we can also use other drugs different from anti-TNF alpha in patients with a truly refractory disease. This is the front page of the paper, who formally showed the efficacy of apremilast for ulcers in Behcet syndrome a few years ago. And as already said, this is the only one drug available, the only one drug approved, sorry, for this disease. But thanks to some papers, some works from the David group, we also know that for anti-TNF alpha refractory patients, we can try to use, for example, ustekinumab, which is an anti-IL-12, anti-23 drug, which is effective not only for oral ulcers, but maybe also for the articular involvement. And this is a paper together with another by our group who showed quite similar results with another drug interfering with IL-17, which might be useful for patients, again, with mucocutaneous and articular manifestation refractory to adalimumab or infliximab. Looking at the ocular manifestations, so in up to 10% of patients, we have only anterior uveitis. And if you have a patient with only anterior uveitis, which is quite unusual, but you can only use topical drugs. Otherwise, if you have patient with very more severe ocular manifestation, for example, azathioprine or anti-TNF alpha agents or interferon alpha can control posterior uveitis, panuveitis, or retinal vasculitis. And more recently, there are data also coming again from some David Saadoun studies suggesting that tocilizumab might be helpful in patients refractory to traditional DMARDs or anti-TNF-alpha agents or interferon alpha, especially for more severe of their manifestations. So the vascular involvement, which is something very unusual if we look at the venous involvement. First, describing the arterial treatment of these patients. This is something that we already know when treating aneurysms in other systemic vasculitis. So we can use systemic high-dose corticosteroids together, usually with cyclophosphamide or anti-TNF-alpha agents. Azathioprine might be used or can be used for remission maintenance purposes. And again, for patients who are refractory to this first line of drugs, few recent data suggest that for arterial involvement, tocilizumab again might be helpful. On the other hand, the vascular involvement is something very peculiar in medicine, because for venous thrombosis, for deep vein thrombosis or recurrent superficial vein thrombosis, the EULAR recommendations suggest to use immunosuppressants. So the cornerstone of the treatment of patients with venous thrombosis is corticosteroids together with azathioprine. Again, in patient refractory, we can use adalimumab and infliximab, and more recently, the Gunnar and Hatemi group also showed that interferon alpha can be useful for patients who do not respond to azathioprine. While there are few data, more recent data suggesting that for truly refractory patients, baricitinib, so a JAK inhibitor, might be helpful. And what about anticoagulants for the treatment of venous thrombosis in Behcet? There are 4 main studies, all retrospective, suggesting that the addition of anticoagulants to immunosuppressants does not seem to add anything in terms of efficacy, evaluated both in terms of recurrence of the disease or resolution of the thrombus at ultrasound. So the EULAR again suggests to firstly use immunosuppressants, and then physicians may add anticoagulants based on the clinical manifestations of the patients. Of note, the use of anticoagulants might be, on the other side, useful for reducing the risk of post-thrombotic syndrome. There are very few data at present. I would say this is the only data we have on the use of direct oral anticoagulant for the prevention of venous thrombosis in patients with Behcet. Again, it's a study coming from the Paris group. And these are very interesting data, despite on a quite small multi-center cohort of patients, because firstly, they described that the use of direct oral anticoagulants alone or together with traditional DMARDs are able to significantly decrease the risk of recurrence in patients who already had vascular manifestations. Looking at the neurological involvement, for sure, systemic high-dose corticosteroids together with azathioprine or anti-TNF-alpha agents in severe patients are the mainstay of the treatment of these very severe manifestations. We can use methotrexate, especially for the so-called chronic progressive neurobehcet, which is clinically characterized by non-acute manifestations developing during the years. And more recently, there are some data suggesting that mycophenolate and tocilizumab again might be helpful. And finally, the gastrointestinal involvement, which is quite rare in Europe, while it's very, very frequent in Asia, is mainly characterized by the use of salicylate for example, mesalazine and azathioprine. The use of corticosteroids is it's a little bit debated because corticosteroids can facilitate the perforation of the colonic perforation. So it's something that you have always to keep in mind when treating patients with a very acute gastrointestinal manifestation. And again, anti-TNF-alpha agents and thalidomide can be useful for more severe forms. And there are some data, again, recent data, which suggest that methotrexate, again, ustekinumab, JAK inhibitors like baricitinib, and calcineurin inhibitors such as tacrolimus might be helpful for treating patients with gastrointestinal involvement. So the key points of these short presentations are that Behcet is a complex disease with a relevant burden of morbidity, especially thanks to oral and genital ulcers and uveitis. Male sex, an early disease, and obviously major organ involvement, particularly the neurological and the vascular one, concur to increased mortality in patients with Behcet. Low-dose corticosteroid colchicine and apremilast are the first line of treatment for mild mucocutaneous and articular manifestations, while low-dose corticosteroids or topical corticosteroids are useful and for anterior uveitis. On the other hand, use of traditional DMARDs, biological DMARDs, and JAK inhibitors are the treatment of choice for recurrent or refractory bone or for more severe forms of this disease. And thank you very much for your attention.
Well, thank you, Giacomo, and great to see the advertisement for the Trieste meeting next year. I'm really much looking forward to that. So may I start with one question regarding treatment? So JAK inhibitors have been associated with thrombosis. Is there any association reported so far between JAK inhibition and thrombosis in Behcet's?
As far as I know, there are no data on JAK inhibitors and thrombosis in Behcet. As I show you, there are very, very few data on baricitinib on venous thrombosis for patients with Behcet. We also have to consider that is it true that all autoimmune diseases have an increased risk of thrombotic events per se, but I really think that Behcet is something different from other systemic autoimmune diseases. So there is something missing in the pathogenetic mechanisms of this disease that might explain why JAK inhibitors might be helpful rather than be harmful in treating patients with vascular involvement.
When I read I think it was in the Lancet review about the central femoral vein and the assessment of it, how do you explain that there is such a major difference? Is it that, you know, some kind of thrombosis in the lower extremities are just...
No, I don't really think it's something related to thrombosis for several reasons. First one, because both patients having or patients not having vascular manifestations have an increased vein wall thickness. And there is a quite recent study again coming from colleagues from Turkey using like a whole body MRI, showing that this is something that you see in any kind of vessel, so not only at the lower limbs level. And maybe also more interesting, there are data coming from pediatric populations suggesting that this is something that you can also see in childhood. So I think this is something unrelated to more traditional cardiovascular risk factors, and this is something related to, as David already showed us, something related to a persistent inflammatory damage of the endothelial wall at vein level, which is able to increase, I guess, but it's something very interesting. I think it might be worthy of histological studies, for example, for understanding a little bit more in detail the nature of this thickness.
So next question would be for David. Do you think that we will see some kind of diagnostic criteria? Because I think in most of the vasculitis syndromes, we are stuck with classification, but no diagnostic criteria. Is Behcet's different or?
Yeah, I think it's really difficult because it really implies also the imaging. It's not only clinical, it's also imaging. So it's really difficult to find the good tools for the imaging part, for the CNS, for the vascular, and also for the clinical part. So I would say, I think, in my opinion, there's 3 different organs that are really critical to define as a single organ manifestation in Behcet, like the uveitis, the vascular manifestation, and the CNS manifestation, because we know that any delay in treatment of this manifestation is really deleterious for the patient. So I think there's a huge need, unmet need for to define that. And I think with Giacomo and other colleagues, we have to deal with that, because it's really critical to find a way to develop this criteria for this very severe manifestation.
I think is again, Behcet is something different from other systemic vasculitis. I mean, we do not see the same clinical manifestations in the same region. So I can imagine to have like general diagnostic criteria coming from a few countries. I think that there are some areas which need some specific diagnostic criteria, while other needs their own diagnostic criteria. For example, if you look at the pathogen phenomenon in Europe, it's really uncommon, while again in Asia, it's really has a very high prevalence, like the gastrointestinal manifestations. We already said that Europe is really uncommon, while again in Asia is really common. So sometimes the Turkish colleagues show us very impressive images of some kind of vascular involvement. So I don't think Behcet is the same in each country. So this is something that we have to take in mind when considering the development of new diagnostic criteria for this disease.
And basically to both of you, so once these people are migrating, and we have, of course, a huge Turkish population as well, I've seen that, you know, the incidence prevalence decreases, but are the symptoms pretty much the same as you would see them in Turkey, or are they also like different? It's like adjusting to Middle Europe, more or less.
So you mean the prevalence of the disease for a patient, for Turkish patient in Germany, for instance, you mean?
Yeah.
It's usually the role of both the genetics and the environment also. So that's why I think these 2 components of the pathogenesis are really critical to explain the lower prevalence of Behcet in immigrants from Turkish that are coming in Germany. But looking at the manifestation, I think clearly there's geographic different phenotype according to the GI, as Giacomo said, for higher GI prevalence in Asia and a different type of manifestation. But I would say at the end of the day, for some of them, I think we can see it's quite common CNS manifestation also for the vascular manifestation. After that, you have to deal also with the delay of diagnosis. We have probably more delay in some countries than the other, because we know that the prevalence is different in North America as compared to some part of Europe. So also, if we have more delay to diagnose, the presentation might be more severe also. That's why it's really difficult to be totally sure that the presentation is really different, and it's not only based on the delay of the diagnosis and so on, but yeah.
And if you have a patient with high suspicion of Behcet, do you perform genetics to test for HLA-P51? Does that have any value in your clinical routine?
Usually, I'm gonna say for my country, and Giacomo would say after what does he think about that. But in my opinion, it's really costly, and it does not add so much, because 50% of patients share this HLA, and if we are quite sure of the diagnosis, there's no adding value. For some of them, in some difficult cases, I would recommend to do this, because sometimes it may help to comfort the diagnosis, but that are very a few proportion of the patients.
Yeah, I fully agree. If I can add just a few things, I fully agree with David. I don't really think testing HLA is helpful for the diagnosis of Behcet. This is something that we obviously do in our clinical practice, but more for research purposes rather than for clinical purposes. When I have a patient with an incomplete Behcet, so a patient in which I suspect a Behcet disease, but without an overdiagnosis, usually I make two main things. The first one is to test for the pathogen with the self-saliva. So using the saliva of the patients, because this is something that has been demonstrated to increase the sensitivity of the test. And actually, the second thing is to perform the ultrasound of the common femoral vein to test the thickness of the vein, which is something that is really helpful. This is something that has not been validated, obviously, but it can help to identify, to add some pieces to the puzzle, to perform the whole diagnosis.
I have one last academic question, and then in the interest of time, we have to switch to the touristic part. And I would really recommend all our colleagues to read both articles. They are really comprehensive, give so much information. I learned for the first time that this is one of the few diseases where smokers have actually less symptoms than non-smokers, whereas spicy food actually contributes to symptoms. But my last question would be, I also learned that while much of the evidence for treatment is based upon cohorts and small studies, there's one randomized study going on in France again, the ETAC study. How far has this study been gone so far, David?
Yeah, we just presented the result in EULAR. It's a phase 2 study comparing infliximab to cyclophosphamide in severe manifestation of Behcet, meaning the vascular manifestation and CNS manifestation. And in this study, infliximab did better than cyclophosphamide to reach complete remission at week 22 with a standardized decreasing steroids dose to achieve 0.1 milligram per kilo per day at week 22. So in this trial, infliximab was really superior in terms of complete remission at week 22. It reached 80% of complete remission as compared to 60% in the cyclophosphamide group. For the CNS part, the group was smaller, so it's more difficult to conclude for this manifestation.
Thanks so much. So, Giacomo, take us back to northern Italy before we end this webinar in Paris.
Okay, perfect. So this is a full picture of Firenze. This is my birthplace, the place where I was born almost 44 years ago, and which is a well-known city in the center of Italy, and is like the cradle of the Renaissance. And it's really difficult to describe Firenze in a few slides. So there are some very famous and fancy spots. So this is Ponte Vecchio, which is the old bridge along the Arno River, which is really nice in the very city center of Firenze. This is our dome, so the cathedral, close to the Battistero, which is both are really, really powerful and terrific monuments of the Renaissance. All the city, I would say, is like living in almost 700 years ago. And I strongly suggest to visitors to also have a walk to the hills surrounding Firenze, because they are very nice. This is a very nice landscape, I would say. This is a garden up to the city center, close to the Boboli Garden, which is a very huge garden close to Palazzo Pitti, another important monument in Firenze. And this is Fiesole, which is a very nice small village close to Firenze, up to the hills. And so this is something that I really, really suggested to visit. But as Gunnar already said, I recently moved to Trieste, so which is again in Italy, and it's in northeast of Italy. It's a little less glamour and fancy than Trieste, but I think it's a very nice Austro-Hungarian city. And this is a picture of the Piazza dell'Unità, which is the Unità Square, which is the largest square in Europe in front of the seaside. And it's very, very nice, especially at the sunset, like in this picture. And this is Castello di Miramare, the Miramare Castle, which was the residence of the Empress Elizabeth during the Austro-Hungarian Empire, which is really, really nice. And this is something very funny. This is one of my favorite places in Trieste. Is Bagno alla Lanterna. It's like a bathhouse, but it's very nice because it's the only one bathhouse in Europe segregating men from women. And this is something funny. You can see here from this picture that in the men side, it's a very relaxing place, while on the other hand, on the other side, the part of the women part is really crowded with a lot of yelling and shouting people. And it's something also interesting because people in love, so men and women, try to have a small swim to meet here where the wall is finished. And finally, this is the last slide of Trieste. This is Barcola, which is the place where I live. My home is up to here, and so I really think I'm happy both to because of my birthplace Firenze, but also thanks to Trieste, the city where I'm actually living. And as Andreas already said, I'm really happy to invite you all to the next European Vasculitis meeting, which will run in Trieste next year from May 21st to 24th. Thank you.
Thanks so much. And now finally, Paris.
So it's really subjective, and I know that Alexandre Carras already talked about Paris. So in my opinion, I select the place I love to visit, to go to visit and to spend time in Paris. Usually I like the garden, and the first one is the Jardin des Tuileries, which is a really beautiful place. And especially because there are very nice museums around. There's the Musée du Louvre, which is very, very nice. And I really enjoy, even if I live in Paris, really enjoy to visit again and again. And also the Jardin des Tuileries is really close to the Musée de l'Orangerie. And this museum of de l'Orangerie, you have a beautiful picture of Monet and other impressionists. So I recommend also this really nice museum, which is also within the Jardin des Tuileries. On the other side, I really enjoy walking within the Jardin du Luxembourg. The Jardin du Luxembourg is within the Quartier Latin, which is really nice to spend some time. There's some restaurant, there's some bookstore, and also there's a small museum, the Musée du Luxembourg. So it's really nice. You can spend some time. You can walk, you can sit. It's really, really nice, I think, to spend some time in this place in Paris. Then I really enjoy this quartier, Le Marais, which is the old Paris. It's a really, really nice country yard of Paris. You have a really small streets with many restaurants. And you have also a very nice 17th century townhouse like this Hôtel de Sully, and you have many gardens, many townhouses to visit. And also there's many galleries, and you can spend some time to walk around. And it's really, 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 really nice place. I really recommend this place. Then there's a famous place, the Montmartre. Montmartre is really nice also because it's an artist place. There's many, many artists, many painters for a long period of time. There's a Basilique du Sacré-Cœur, which is really nice to visit. There's many theaters just around the place. Also many restaurants, so you can walk in the street and you can see it's really, really cool. And I think it's a very nice place of Paris also, not so crowded and very, very interesting. And then to finish, there's many different places, but I think there's different parks you have to know that are really, really nice. I like the Parc Monceau. The Parc Monceau is a very nice garden in Paris in the 17th arrondissement of Paris, which is really a nice place. There's many restaurants around, many stores, and you can walk around. It's really, really nice. And just in the suburb of Paris, there's a Parc de Bagatelle, which is also really nice. It's a really nice place, just in Neuilly-sur-Seine, just 5 minutes from Port-Maillot. And that's a very, very, very nice place that I recommend also to visit. It's really close to Paris. So I think that place would be really sympathetic to visit even during the Olympic game.
Andreas, one day we have to have a special edition from Marcus at Home from Paris after all these recommendations of the 2 last years. We are really amazed to see ever new ideas where to go. So I was not aware of Trieste. Honestly, this would be a first visit for the majority of us, but Paris, I guess everybody thinks he or she knows the city, and then again, you always give us nice ideas again. So thanks so much for taking both challenges, both the academic one and the touristic one. Thanks so much. Have a nice last Olympic weekend. Thank you.
Thank you very much.
Thank
Bye.
you.
See you.
Bye-bye.
Thank you.
Bye.
Bye-bye.